Well, I guess it's that time of year again, although for letters of recommendation, it seems like it's never ending. Certainly this time of year is when we tend to have more requests for letters of recommendation, and I think all of you may have been reached out to by the residents who are applying to fellowships right now. I think the challenge is that there's really no great studies showing how effective these are. And I think that as time's gone on now, we are realizing how important they're actually becoming for a variety of reasons. So let's start with this. I think if you read a lot of them, they all seem like everybody walks on water, but I think that's the challenge, is finding those that truly do and those that may swim and not sink, and then trying to really identify the ones that are going to sink. So I think there's a number of reasons why this has really increased in importance. I think the first thing is the changes in curriculum across medical schools. There is becoming more and more limited measures of performance. And and I would say the majority of medical schools now, especially in the basic sciences, have moved to strictly pass-fail basis. Several of them continue to maintain a satisfactory, near honors type of rating as they go through clinical rotations. However, some medical schools have moved to pass-fail completely across all 4 years. And therefore, there is really no delineation between students at all from that. I think the other issue that we have, especially in the honors system, is the number of schools that have really inflated those grades. They know that programs will actually look at honors, the number of honors on rotations, in order to select candidates for their applications. And so I know some of the schools that I look at applications from, close to 80% of their students get honors on clinical rotations. So therefore, it really means nothing whatsoever, that system anymore. I think it really requires that we go through more of a holistic approach when we actually look at these applications and select candidates for interviews. I think the mainstay has always been the USMLE scores. I think step one really has been the primary screening tool when we're looking at residency. But as of 2022, this is now also moving to a pass-fail basis. And so we're going to eliminate another resource to look and see how we can rate candidates for the positions. The other thing I think is important about USMLE scores is that step one, there is a correlation with people that perform well on those, performing well on credentialing or subspecialty board exams and pass them first time they take them. However, there's zero correlation of how good they are with patient care. And I think that's one of the things, we use it as a primary screening tool, but what we're really interested in, especially in pediatrics, is their ability to care for children. So I think the other problem is now with grades that are no longer there, we no longer have class rank. And so we also now lose that ability to say, this student in that cohort of students performed better than another one that would let us know that they may be a really good candidate. And then the MSPE, or the Medical School Performance Evaluation, this is the dean's letter. They have tried to standardize the format of it. However, not everybody follows it. And in this, the mainstay was to make sure that they documented if somebody remediated courses or actually had a leave of absence and why that was. But not all medical schools follow that. And so again, it doesn't really become a useful tool to actually to evaluate the applications and select these candidates. So then it comes to a letter of recommendation and the question of, are these a good tool and can we really rely on them? And then the other thing that's in there is their personal statements. And certainly the students are going to write these. Their goal is to sell themselves. So but you might get a glimpse of their personality by reading these. And I think that's what's really important with a personal statement. And now this year in particular, and who knows if this is going to carry on into the future, is we are now moving to all virtual interviews this year because of COVID. And I think this really takes away this benefit that we've had of in-person interviews and really getting to know that candidate personally, see if they're a good fit for the program. But also, they're going to miss out on seeing our program and evaluating whether or not it's a good fit for them. I think what's going to become important is the local students know this program the best, and we have the benefit of having a whole bunch of students this year interested in going into PEDS. I think that's going to benefit us greatly. But I think in the long run, it's still going to be a bigger challenge to kind of try to decide which students we actually invite for interviews. So in June of 2018, in the Journal of Graduate Medical Education, there was an article that was published, Dear Program Director, Deciphering Letters of Recommendation. And everybody felt that there probably was a code that program directors looked at and used in order to evaluate letters of recommendation. That's really what this paper was about, is trying to see if that was true. I think all of us know and have written letters thinking to ourselves, well, now how do I put this without sounding too harsh? Or how can I truly sell this candidate? And what kind of words do I use? So we are using a code. Maybe it's just in our mind, but maybe it is across the board. So this paper got published, and then what they did is they did a second study. And in this one, which was just published in November of last year, they actually sent out the questionnaires to not only the pediatric program directors, but also surgery and internal medicine to say, does this carry true what we found in PEDS across the board? And what's interesting, there were some statistical differences. However, there were a lot of correlations. And they truly said, yes, there is a code, and there's things that we look for in these letters that really rate these letters higher. So they really kind of looked at the importance aspects of these letter recommendations as far as feature of the letter, the attributes of the applicant, and then also looking at the program director's interpretation of the phrases that were actually in there. Here's some interesting things they found. If you look here, 78% of PEDS, 85% of surgery, 73% of internal medicine program directors rated their letters of recommendation as important. So we know that, well, 2 or 3/4 of us actually do feel that they're very important in selecting these applicants. I think what's even more important is that the next statement there, that 87% of PEDS, 89% of surgery, 86% of internal medicine program directors would lead to tend to consider a weaker candidate more favorable if they had a good, strong letter of recommendation. And then in converse to that, if you have a poorly written letter of recommendation, 61, 70, 64% of the program directors really considered a strong candidate less favorable. And I think this is a tough one for me because these candidates waive their rights to these letters. They don't ever see them. They have no idea what's in them. Yet if it's written poorly, it reflects poorly on that candidate. And I think that's something really important as we write letters to really keep that in mind and consider. So there were 13 features of these letters that they actually looked at, and these were the 5 most common and most important aspects across the board. They were weighted a little differently depending on the subspecialties, but that depth of interaction with the applicant, PEDS and internal medicine wanted to hear the story. They wanted to hear how you were involved with the applicant, where it was less important with surgery. Specific traits of that applicant. And so being a team player and hard worker and those kind of things were what PEDS and internal medicine really wanted to hear, but surgery, it wasn't as important. The feature in surgery that they really wanted to see and hear is that the student was resilient. And I think it's something that one of the problems with these studies is they didn't take into account how long somebody had been program director. And I will tell you, being program director for 10 years, I look at letters of recommendation much differently now than I did when I started. So, and that may have had a role to do here. That applicant's ability, how well they can take care of patients, how well they work in those teams, all of those kind of things actually come out. Again, peds and internal medicine, it was more important than surgery. But some of this statement on the strengths of the recommendation and the strength of the recommendation was much more important on the surgery side than it was actually on the internal medicine or peds side. And peds really didn't look at a summative statement as actually all that important. And then that personal story about the applicant, internal medicine, they rated it higher than peds did, and certainly rated it higher than surgery. And surgery was fairly low as far as looking at and thinking of that personal interaction, and having that personal story was not that important. So I think there's some differences, but actually what they found is that all of these things were actually rated higher on those 13 categories as far as what's important in the letters. So looking at residency versus fellowship program directors and their interpretation of letters of recommendation, this was really only addressed in the first study. They did not address it when they sent it out to surgery and internal medicine. However, there are some things that kind of correlated with both internal medicine and surgery in these areas. So the 5 features that were really statistically significantly different for fellowship directors versus the residency, one was participation in research. And I think that that becomes very important, especially in pediatrics, because all of the programs require a certain length, at least 12 months of research, and some of them are much heavier than that. So having that exposure becomes very important. Advanced degrees held by applicants, and I think that's really interesting, whether or not they had MPHs or PhDs or anything else that went along with it, tended to rate that applicant higher with fellowship directors than residency directors. But other thing that's interesting is involvement in the program and hospital activities. And certainly I can see the difference between a fellowship and a residency. In students in medical school, they may not have the ability to participate in hospital activities or certainly in the program activities, but residents do. And this really is developing a lot of those leadership skills, and that's what they're looking at. Now, in general, peds and internal medicine look for those extracurricular activities with applicants applying to residency, but not necessarily specifically for hospital or program type of activities, which is what they want to see in fellowship letters. That academic rank and a known letter writer. This is really interesting. This gets to the old adage that getting into a fellowship is who you know and not what you know. I think the ARIS application system has mellowed that, belief. However, I think it still holds true. We still have a lot of our residents that get interviews at places because the program director knew a letter writer and respected that letter writer. So I think that this still does hold true. What's interesting in residency is only surgery felt that this was really important when they looked at letters of recommendation compared to internal medicine and pediatrics. So, and then this length of the letters, greater than 4 paragraphs. And I think makes sense with fellowship applications. You know these residents better. They actually have more experience with patient care and more experience with research and those kind of things, and all of those want to be incorporated into the letters. So, but surgery and internal medicine also really prefer to have longer, lengthier letters. I will tell you, as a program director, reading through 1,000 applications a year, I don't like to see long letters of recommendation, just for the sheer fact of time trying to get through them all. So these influential phrases, I think the positive ones, would like them to stay at our institution, or you want to pursue them heavily to stay here. that they'll be a great asset for the program and describing how they would be an asset. They exceed your expectations, and you would give them my highest recommendation. Those phrases were felt to be very positive in the letter. There were a lot of these neutral phrases: I recommend, recommend without reservation, highly recommended, solid performance, were just kind of neutral. Didn't affect them one way or the other. But all of the subspecialties really felt that these three statements, the negative ones, really were a negative effect on the applicant, and most likely would result in not inviting the applicant. So, and what's really interesting, the first one showed improvement. And I think that we want all students to show improvement and residents show improvement, but it becomes a very negative statement when it's a letter of recommendation. Like there was a flaw to begin with and they had to improve upon it. So I would avoid that one if you're writing letters of recommendation. And then overcame personal setbacks. They really wonder what were those setbacks and why did they have them? And then performed at an expected level really states that they just were average. And so that becomes actually a very negative connotation as well. So when you're writing these letters, what it's going to be required is with the letter of recommendation portal on the AAMC website, you have to have a code first, which you have to get from the applicant. I would recommend that when you write your letters, you have somebody else read them over. I write stuff all the time. When I reread it, I put words in there that are not there because in my mind they're there and I don't see them, but they're there. And that's what I typically find. Punctuation, misspellings, all of those kind of things, even with spell check, they'll throw in different words in there that really throw off the meaning of it. So have somebody else read your letters of recommendation before you send them out. It has to be on professional letterhead. I think there is a electronic copy of the letterhead that you can get if you need that, so that you can get these letters written on the professional letterhead. You need to include a date on them. I frequently see letters that were written 2 or 3 years ago, and they must have just re-uploaded the same old letter of recommendation. It has very little meaning to me at that point. And then they have to be signed by the author. And what's recommended is that you sign them in a different color than what is the printed ink. So most of the ink is black. And so if you have a blue pen to sign those letters, when you scan them into the system, it will show up blue and they'll know that it's actually your actual signature. So you can certainly sign them electronically, that's fine. But that's what they would prefer is to show that it's actually an original signature. I would also include the applicant's name and their AAMC ID. This comes on the ticket that you get from them, the code that you get. It actually has that information on them, exactly how their name appears in the application, their AAMC ID, just in case they get lost. And I think one really important thing is once these are uploaded in the system, you cannot remove them or change them in any way, shape, or form. So if you make a big mistake, it becomes almost impossible to actually get it deleted or changed. So a couple other things. If you cannot write a strong letter for an applicant, don't write one. Like I said, a poorly written or a bad evaluation on a strong candidate will reflect terribly on that applicant more than 50% of the time. So tell them you don't have enough experience, that you just don't have time, you don't feel that you can do it, whatever it is. And most of the candidates will graciously bow out and find somebody else. The length, I think they need to be at least 3 paragraphs. I think it should include that introduction, what your academic rank, what your affiliation with the student or the applicant is. The middle one, kind of a detailed assessment of their abilities, how you worked with them, if there was research, if it was actually clinically. And then a conclusion as far as keep in mind those negative and positive phrases that I mentioned as you write your conclusion, because I think that's what the ending thought that the program director will have. I think that multiple pages and length really depends on what type of application. If it's for fellowship, if it's something that you had really worked long time with the student that you've gone through medical school all 4 years, those kind of things are going to be much longer than actually if you're just on a clinical rotation with them. And then I think when you're looking at the applicant's ability to really think about the 6 core domains of medical education, so that patient care, their medical knowledge, systems-based practice, so can they assess the system and decide what kind of quality measures need to be looked at and actually improved upon, practice-based learning and improvement, can they identify their knowledge gaps and actually make changes, find resources, and actually move forward with those things. Professionalism, and then also certainly the interpersonal skills and communication, I think, are really important to include in those comments on those. So the goal overall, find those that sink, swim, and also those that truly walk on water. And I think this is going to become very important this year. We need to have a glimpse into who they are and how they perform clinically, and I think it's going to be a challenge since they missed the last 3 months of their clinical rotations in their 3rd years. We even have less experience with them. So I guess I'll ask for questions, but it's only the people here in the room if they have them. Otherwise, certainly if you have questions, send them out. Stephanie is going to send my PowerPoint and both of those articles that I mentioned out to you, so you can read through them and look at what it says in there. So, but I probably went over too, as usual.